Case 1 involves a 47-year-old female who is referred for ultrasound with palpable nodule. Ultrasound demonstrates one nodule, and it is our job to decide which category this nodule falls into. Not only do we characterize it based on the TIRADS stratification, but then we look at the size to help guide our management. Here is our nodule. And to break this down piece by piece, our nodule measures about 3 by 3.2 by 4.8 centimeters. As you can see, the calipers are a little off here. It isn't first of all, it should be measured in the transverse, measuring the greatest dimension in transverse, and then perpendicular to that dimension. So the dimensions here, as saved by the original images, should not be used, but you should probably remeasure it yourself and then guide your technologist on appropriate measurement. It's located in the right mid-thyroid. It is certainly over 5% cystic, so it's mixed cystic solid. Lots of eccentric solid component. That solid component is isoechoic to the thyroid parenchyma. It is not taller than wide. It is based on the margins of the soft tissue component. You can consider it irregular. It does have punctate echogenic foci as well as large comet tail. Technically speaking, we can add calcifications. Adding all of this up, 1 plus 1 plus 2 plus 3 equals 7. And that puts us in TIRADS 5. And then based on the fact that it's over 1 centimeter, fine needle aspiration is recommended. So summary, in our report, nodule, TIRADS 5, measures over 1 centimeter, fine needle aspiration recommended. Some teaching points here. Remember, eccentricity is important for solid component. Particularly evaluate the margins of the solid component, not necessarily the cystic component. If the calipers are incorrect, they may not be perpendicular, they may not be on the transverse image. Remeasure the nodule on your own in the axial plane. And finally, the representative images here, the original two, did not show punctate echogenic foci. But having the original image to scroll through shows punctate echogenic foci, which greatly alters your interpretation and management of this nodule. In terms of final pathology for this nodule, fine needle aspiration showed benign follicular nodule with cystic change and a single minute focus of calcification. FNA was performed on 4 separate times over several years, as recommended by the patient's referring physician. The nodule was increasing in size over the last decade due to its cystic component mainly, so surgery was offered. A right subtotal thyroidectomy for multifocal papillary thyroid carcinoma was performed. 4 lymph nodes were removed and they were negative for malignancy. Moving on to case 2, we have a 50-year-old female with 1 nodule. She noticed the lump herself. This is that nodule. Quite irregular, mixed cystic and solid. I believe the calipers here are much more appropriately placed. And again, same question we face every time. It's a multiple choice question every time we get this with a thyroid nodule. This nodule, dimensions are as given. It's located in the right mid-thyroid. It's certainly mixed cystic and solid, and the solid component, when scrolling through them, it's really isoechoic. This is wider than tall, certainly not taller than wide. The margins of the solid component are very irregular. Foci, there's no echogenic foci. Points total about 4. This measures this measures greater than 1.5 centimeters, so FNA was recommended. This isn't 95% solid, therefore it is mixed cystic and solid. Some would consider it predominantly solid, but I do not consider it 95% solid. Pathology results in this case, FNA showed papillary thyroid carcinoma. On examination, the surgeon felt that the mass was fixed to the trachea, so a CT was performed showing the mass with no obvious gross invasion. However, surgery revealed lots of invasion, including extrathyroidal into the lymphovascular structures and perineural structures. Due to the advanced local involvement they found, thyroidectomy was actually in 2 stages to ensure the laryngeal nerve was preserved. The right hemithyroidectomy confirmed an advanced T4 papillary tumor, and the left confirmed some micropapillary carcinomas, which were not visible on either the CT or ultrasound. Moving on to case 3. In case 3, we have a 7-year-old man with incidental thyroid nodule evident on CT. This is that nodule, measured appropriately in transverse and sagittal plane. Again, that's our question to ask. In this particular case, the nodule is solid. One would debate whether it is hypoechoic or very hypoechoic. On these selected images, you could argue it is very hypoechoic relative to strap muscles. It is wider than tall. There is macrocalcifications with posterior acoustic shadowing, and there is punctate echogenic foci elsewhere. And these are summative, so you'd add it. So whether you call this very hypoechoic or hypoechoic, it's not going to change the overall risk category. It measures over 1 centimeter. It's still a TIRADS 5. That's the main summary here. And the main teaching point here, which sometimes escapes people, is that you can add calcifications. They are summative. In this particular individual, FNA showed a papillary thyroid cancer, and total thyroidectomy revealed a T2 papillary cancer. Case 4, patient referred for throat discomfort. Not an uncommon history. This individual had 2 nodules present on their ultrasound. Here's the first nodule. That's what we need to ask ourselves. And for this nodule, it's located in the right lower thyroid. Lots of healthy debate among me and my colleagues about what to call this. You could call it almost completely solid, or you could call it mixed cystic solid. Now, I do not think this is 5%. I think this is over 5% cystic, particularly when you scroll through it. So I would call this mixed cystic solid. I would call it hypoechoic relative to background thyroid parenchyma and wider than tall. I'd also call it ill-defined, but you could argue and debate it calling it smooth. Certainly no echogenic foci evident. So you can make it a TR3 or a TR4. Regardless, because of the size, FNA is recommended. Here's our second nodule. Again, there might be some debate about what to call this. Depending on the day, this might be a spongiform or a mixed cystic solid. One could err on the side of caution and call it a mixed cystic solid. And then it is isoechoic, wider than tall, no echogenic foci. So no follow-up or FNA recommended regardless of whether you choose to call it mixed cystic solid or spongiform. That would be your summary statement for your report. Teaching point here, just to reiterate, I spent a lot of time going through the webinars and the papers, really trying to discern the spectrum between spongiform, mixed cystic solid, and solid. And from what I can interpret from everything there, if a nodule is over 95% solid, then it is classified as solid or almost completely solid. And I consider 2 of those to be synonymous. Solid or almost completely solid. If it is less than 95% solid, it's considered mixed. If it is less than 50% solid, then it is spongiform. For nodule 1, you may have bumped up the total points to 4 points, but because of the size, FNA still would have been performed. In nodule 2, we could debate whether it was pseudospongiform or spongiform. Didn't change management in the end. Pathology results of this nodule revealed a benign follicular nodule. In case 5, a 7-year-old man presents with voice hoarseness and shortness of breath. Ultrasound demonstrated 5 nodules. So here's our first nodule. That's the question we face for it. So for nodule 1, it's located right lower. It's certainly solid, no debate over that. I would consider it hypoechoic. You might debate calling it very hypoechoic. It is taller than wide, smooth, none, and those total up to 7 points, giving it a TR5 with recommendation of FNA. And our second nodule, definitely some calcifications in this one. It measures a little smaller. It is certainly solid. It's got hyperechoic components. I think it does have some small cystic proteinaceous components in it. I would consider it predominantly solid. Wider than tall, with smooth margins. And calcifications here I would place peripheral rim. You could also call them, I would call them peripheral rim. There's peripheral rim calcifications. I would not classify this as macrocalcs. Regardless, it would still bump the total points quite high enough to make it a TR4, and it's over 1.5 centimeters, so FNA should be recommended in this one. Not quite finished with the right thyroid here, and here's our third nodule for the right, not far from the one we just looked at. This one measures a little bigger. Solid. This one is a straightforward hypoechoic, and it is taller than wide, with smooth margins. The taller than wide really bumps it up at 3 points, making it also amenable or necessary, recommended for fine needle aspiration. Moving on to the left thyroid, here we have an isoechoic nodule. Take a second to look at that. For our left upper nodule, it is solid isoechoic, wider than tall, smooth margins, giving it a TR3. And for TR3 nodules over 1.5 centimeters, we do follow them at 3 different intervals. 3 different intervals for TR3. A little more inferior, we have the left thyroid nodule. Size dimensions are as follows. I think it's measured reasonably well. Solid, isoechoic, wider than tall, smooth, giving it a TR3 that we would again follow. So you can imagine that would be a fairly long report. Detailed, comprehensive, but long. Which is synonymous really. Detailed and comprehensive equals long. So my summary would itemize each nodule. I wouldn't necessarily include the points or the size dimensions, but I'd say nodule 1 is a TR4, FNA recommended, nodule 2, TR4, and so on and so forth. Now I will point out that the ACR committee recommends that no more than 4 nodules with the highest points should be followed, as detailed reporting of more than 4 nodules creates a very long, complicated report. They also recommend that we should target no more than 2 nodules with the highest points to sample FNA. Again, highest points, not size. So one must look at your points in order to determine which 2 should be sampled. In our case, if we were strictly following the guidelines, we'd recommend nodule 2 and 3 based on their points, despite the fact that nodule 1 measures the largest, but it has the lowest number of points. Now I will point out at our institution, reporting over 4 nodules may occur, particularly if the patient is a long-term patient. In this particular patient, FNA of one of our recommended nodules did reveal papillary thyroid carcinoma. The pathology report didn't specify. Surgery revealed papillary carcinoma in the right largest nodule, the one with the lowest number of points. And the second largest nodule, the non-calcified one, also had papillary carcinoma. The patient did have a total thyroidectomy revealing microcarcinoma on the left. No invasion. Moving on to case 6, we have a 40-year-old female with palpable neck nodule. 3 nodules were identified on ultrasound. Here's our first nodule. I think you'd agree with me that the calipers are probably a little off in terms of measuring this. Again, probably not going to make a difference in the grand scheme of things as we dive into it. So for this particular nodule, when remeasuring it, I measured it at about 2 by 2.5 by 2.3, and I would consider it almost completely solid. This just looks, one could debate, Angus, this is not 95% solid, so if you really wanted to make it a mixed cystic solid, you could. Regardless, I'm very worried about this as we proceed through the remainder of the characteristics. It's very hypoechoic. It is definitely taller than wide. And in this particular case, there is obvious invasion into the overlying strap muscles. We certainly have some punctate echogenic foci, and we also have some calcifications that are shadowing, making them macrocalcifications. So very high total points here, certainly a TR5, and it certainly measures over 1 centimeter. So that should be sampled. Our next nodule is in the right isthmus. This is a solid lesion that's hypoechoic, wider than tall, and smooth. There are no echogenic foci, and so we can add those up, making it a total points of 4. That leads us to the TR4 category, and it's under 1 centimeter, so nothing recommended. And there is a similar appearing nodule in the left isthmus. This is just measuring 1 centimeter, left isthmus, solid, hypoechoic, again wider than tall. And this one we would follow. TR4, you follow it at 4 different intervals. So the summary here is a TR5 with extrathyroidal extension. I like pointing that out. FNA recommended. TR4, no further follow-up. TR4, follow-up ultrasound 1, 2, 3, and 5. So you could debate about the measurement of the nodule 2. Could we make it 1 centimeter if we went back? Not going to make a difference in this case because you're following it anyway. Plus the patient's undergoing surgery. So there's our nodule 1 that we've called extrathyroidal extension. And in this particular case, while TIRADS didn't cover it, always note the pathological lymph nodes. And I didn't include those in the selected images here, but as you scroll through the DICOM images, you got to look for the pathological lymph nodes that may or may not have been seen, and include those in your findings in your summary as well. So if none of these nodules demonstrated the need for FNA based on TIRADS, you'd be very concerned about sampling at least the lymph nodes and possibly the most worrisome thyroid nodule, depending on what it looked like. This did reveal an invasive multifocal papillary thyroid carcinoma with bilateral lymphadenopathy. Moving on to our next patient, they had one palpable nodule, measured as seen. The transverse measurements are correct. I believe that the sagittal measurements are probably a little off as we go through the original images. And I've measured it to represent that. It is pretty much the entire right lobe. It's very hypoechoic. Now, there may be some debate between me and you and your colleagues about whether you want to call this extrathyroidal extension versus lobulated. It certainly is bulging with no obvious invasion of the strap muscles that I could see. But regardless, the total points are very, very high. There are 11, making this a TR5, so FNA is recommended. I just want to reiterate that bulging does, and this is a very extreme case of bulging, does not equal extrathyroidal extension, but also be aware of pathological lymph nodes. Moving on to case 8, we have an 85-year-old with an enlarging lump, left neck, and dysphagia. So this is a measurement of said left neck nodule. There are measurements of the bilateral. One could debate, does the right look any different than the left? This is an interesting case in that effect, but the fact that he did have dysphagia and a rapidly enlarging neck mass, we did proceed to sample it. To characterize the left-sided lesion, considered it very hypoechoic, taller than wide, lobulated, particularly posteriorly. Kind of hard to see on these images. And you can make it 10 points or 8 points, but regardless, it's a TR5. It should have FNA. Now in this particular case, the patient did have a CT because of that history, and here you can see that the mass does appear more so on the left, and it is invading the esophagus. Now we can debate whether this case really applies to TIRADS. Would you call this a nodule on the ultrasound, or is the entire left thyroid replaced? Regardless, I thought it was a case worth showing to you as a scenario where TIRADS doesn't always fit nicely. Always beware of deep invasive masses. I think the cines can really help pick up deep invasion. I don't think they were readily seen on the static images here. This was an anaplastic thyroid carcinoma. Next case is a 77-year-old female with voice hoarseness. Ultrasound demonstrated 2 nodules. Here's our first nodule. I don't think it takes a TIRADS expert to think that this is a very nasty looking nodule. I think the dimensions of this are pretty spot on. It's located right mid-thyroid, solid, very hypoechoic. Great example of very hypoechoic with no debate on that. Certainly taller than wide. As you scroll through, there are punctate echogenic foci. You can see a couple of them here. You may debate whether this is speckle, but when you go through the original images, I believe there is punctate echogenic foci. Even if you don't want to make it punctate echogenic foci, it has enough. It's still a TR5, and it's over 1 centimeter with FNA recommended. Elsewhere in the left, we have this nodule, which measures sub-centimeter. Oh, I said right lower, it should say left lower. This is a solid nodule. It's certainly 95% solid. It's wider than tall with smooth margins. And it's measures small enough with a low point in stratification that no further follow-up is required. But regardless, FNA of the larger one was performed. In this particular one, I would point out, there's no need to obsess over features if they are at the same point value. So this nodule, we could debate, is it lobulated or irregular? As well, big calcifications don't equal macrocalcifications. If it doesn't shadow, then it's considered punctate echogenic foci. I think there's some challenges in that because this nodule is very, very hypoechoic, and it's quite possible you may be missing some of that shadowing and maybe some weak attenuated shadowing in the first place. Things to think about. I still think TIRADS is a fantastic tool. There are certainly some areas where we may be able to improve upon it in the future. So a total thyroidectomy was performed in this patient who had a papillary carcinoma with lymphatic invasion and positive lymphadenopathy. This 60-year-old had a palpable nodule on the right with 3 nodules. First nodule demonstrated a solid lesion that was hypoechoic. I do not think it was very hypoechoic, but we could debate that. And that may bump it up. You could consider that being very hypoechoic, but as I scroll back and forth through DICOMs, I would call it hypoechoic. Smooth with no echogenic foci. Moving on, however, to the left, we certainly have a heterogeneous nodule with macrocalcifications, some tiny cystic components, and some punctate echogenic foci. It's quite heterogeneous, but I would call it hypoechoic, not isoechoic. It is wider than tall, and I would add the types of echogenic foci here, making it a total of 8 points, and therefore FNA recommended. This particular nodule here is quite hypoechoic, and this is taller than wide.